Okay, 8:03, fashionably late as always. Play it mean, keep 'em keen. That's what I was always taught by Gary Benson, I think it was, on level 5. Anyways, here we go. Thanks for joining us. Apologies for keeping you waiting. Obviously, I'm joking. Before I start, 'cause I always forget, in the post, there should be a little link there for you to click on if you haven't already, which in theory, I'm working on a ticket as we speak in the software for live TV. If you click on that link, it takes you to a blank page, which looks like you've just frozen, but that will mean that your comments and when you comment, your picture and your name will come up, which I think is really important. I'm having a right go at live TV saying, what's the point of having a networking web chat thing if people's names don't come up? But yeah, they just keep saying, if you click on that link, it'll all be fine. So it is in the post. If you notice you'll come up as Facebook user, then yeah, click that link. Otherwise, if it still doesn't work for you, just make sure you do put your name in brackets when you're speaking. Then at least it's for me, really. Everyone else in the room can see you. It's just me. I want to know who you are. Anyway, there we go. That's admin out of the way. Right. Thank you very much for joining us once again. Do I apologize for last week? No, I don't. I had some people saying thank you. It was very interesting. Last week in episode 8, it was Matt Scarsbrook took the reins and he was in the host seat asking questions to me, all about me. And I sat there cringing a little bit, but feedback has been nice. A few people said that was really interesting. It's interesting where you came from. The fact I did NASM was interesting. People saying, should I do NASM? It was a long time ago. I'm old and it was a long time ago. I can't vouch for them now. It got bought by Premier, someone said. I've got nothing to say about Premier either, but no, everything where I came from was 20 years ago. So well past its sell by date in many ways. So yeah, but the path hopefully was common to some of you. I still, like I said, it's available on YouTube. Like I said, I still think strength and conditioning background is really useful. The first course I get any massage therapist moving to sports therapy to do is like a kind of a strength and conditioning, kind of like Claire Minshall type thing where you know about setting strength exercises and progressing and regressing and the importance of all that sort of stuff and working with people. So anyway, apparently there was some interesting stuff there. And like I say, it's not on YouTube yet, but it will be by tomorrow. All episodes are available on YouTube. Anything else I need to say about last week? I don't think so. Lee said probably best, but thanks to Matt Scarsbrook for that. Tonight, dun dun dun, on episode 9 of Let's Talk About in the Sports Therapy Association Open Group, I'm very pleased to hopefully introduce some of you. You may know him already, but Paul Coker, who is a fantastic physiotherapist and by his own words, movement nerd, which I'm sure we'll be hearing a lot about. Some of you might know him as former medical director for Rocktape UK. And he basically is the main reason which, when I was in clinic for 10 years, stuck with Rocktape. He was the reason which made me continue using tape, really. As we'll see from his talk today, and hopefully from anything you read about him and listen to him, I mean, this is my own opinion, but me and a lot of colleagues hold him as that very valuable link between don't do any manual therapy, it sucks, it's rubbish, it's all doesn't involve anything, just get rid of it, and the opposite, where let's just massage patients and do nothing else. It's neither of those two, as always in life in so many cases, neither of those polar opposites are the right place to be. And often there's a lack of speakers and presenters who are in the middle, who maybe not definitely in the middle, because the middle's not always best, but not taking those two argumentative sides and just going like this on Twitter, because that gets you nowhere. So I'm really pleased to bring you Paul. That's how I see him. You can leave comments and send feedback. Maybe I'm wrong. But we'll soon have a chance to see. He was one of the speakers on the Therapy Live package as well. So if you've got your £50 for all of the 73 presentations, Paul is in there. Let's bring up, let's take the solo off. It was a far catchier title than I did for tonight. Where was it? Oh, there we go. Manual therapy through a neurological lens. See, I couldn't fit that on our little advert for Let's Talk About. I haven't got room. Well, so I just put adjuncts. Do we need them? Because I get it, it's like Twitter. But yeah, it's an amazing talk. I've watched it twice now, because I watched it once just after the presentation, because there was a list of people I wanted to see, and then obviously preparation tonight, I wanted to have a look at it again in case there are any questions to talk about. But yeah, if you've already got the package and you're working your way through the 73, then bop that one up towards the top, definitely. If you haven't got the package yet, then tonight after listening to Paul, then maybe you'll be thinking, actually, there's one reason to get the package. Also on therapist learning. Oh, look, see, that's Run Chat Live 2019. There he is in there. Look, you see that picture? This is also the presentation which you did for Run Chat Live 2019 is on there as well, along with other people you can see here. We've got going around the table. We've got Choose there. We've got that Welsh guy who used to have a beard and now shaved it off, so I won't say his name. Ian Griffiths, JF Asculia, Simon Bartold, Izzy Moore, Derek Griffin. Yeah, it's a good company. They're all up there as well on therapist learning at a small price because, hey, we all work and study and we can't just give you everything for free. But anyway, tonight is free. So without further ado, I'm going to bring you up Mr. Move himself, Paul Coker.
No, you're not.
That's not Paul at all. Who are you? What have you done with him?
I love the drama.
Thanks for joining us, mate. How are you?
No problem at all. Very well, thank you.
Everything I said was true. I don't think I lied about you or beat you up too much at all. I'm really thankful for you coming to chat to these guys here tonight. So thank you very much. Before we do, just so I don't forget that there are actually people watching this, because I could just chat with this guy for half an hour and forget about anyone else in the room. So I will say hello to people who's in here. We've got Mark Nusi is back. What's that? 9. Don't forget, Mark, if you watch all 10, then Gary is going to send you a premium quality STA gift of some form. He's already promised that. So Mark, if you come next week for Anna Maria, then that's it. The prize will be on its way to you in the post. Let's get rid of that. Mark's in the house. Timothy Grigg is here as well. Hi, Timothy. How are you? How's it Tuesday already? Oh, I know. Tell me about it. Ryan Smith, thanks for joining us. Gary's in the house as well, in case I say something wrong. That's great. Security's in the house. That's cool. Sports Rehab Clinic, Mark. Nice to see you as well. No misbehaving with 6'12", Gary in the house. Our Facebook user, see, this is Keith Burnett. How come? Have you clicked on that link yet, Keith? I need to see you in your glorious picture filling that square. You can be an experiment for me, Keith. Click on that link in the post and just see whether that changes and you come up. Good to see you, Keith. Hope you're well. We're getting you on the show sometime soon, I know. Here we go. Paul, watch out. Gary knows everything. Paul was one of my teaching mentors back in the day. Genuinely top man. That's cool. I should always read these before I bring these comments up, shouldn't I?
Don't talk me up too much.
Right. Mark Nusi. Oh, Gary's already saying, apologies in advance for the disappointment. No, it's all right. That's Gary's way of saying, watch out, mate. I'm going to send you something huge. Do not go out for the day because it's going to take your breath away. Right. And with their Facebook user as well, whoever that might be, try clicking on that link and then I'll be able to see your fantastic features as well. And let me know if it doesn't work. Fantastic. Right. Any comments and questions you have, don't feel shy. Really, there's absolutely no decorum in this room whatsoever. Just chuck it on there and we will gladly ask the question for you to our guest. Right, Paul, thanks for waiting for that.
No problem at all.
Bam, logo. Now, I apologize because I put you down still as medical director for Rocktape.
Well, that's all right.
UK.
I mean, yeah, I was for a long time, and that's, if anybody knows who I am, that's why they know who I am, really. So yeah, but I left Rocktape at the end of 2019. So yeah.
How long were you there for? Was it a few years, wasn't it?
Yeah, 10-ish. I think I worked it out. Like I think I went in with the guys for the UK company in 2009, but I might be wrong about that. But yeah, certainly the longest I've ever had a job, and I loved it. It was brilliant, and it was just one of those sort of time to move on things, really. That having been involved in what was a small company when I got involved is now a very large multinational company, and therefore kind of things grow and change a little, and sort of, yeah, well, some of the fun's out of it once it's a big multinational like that. So it was time to focus on some other things and move, which is just, started as my clinic room, but now is sort of morphing into other things. That
something huge. Yeah. Well, you were getting too big for Rocktape, let's face it.
I don't think.
Oh no, you were, and you should really get that T-shirt printed. I was
thank you very much. Too big for the corporate world. Yeah, no, it's a funny old place, and people are often very suspicious of therapists who are involved. And as somebody who has been in on the inside, and it sounds like blowing my own trumpet, but sat at the top table. I sort of was closely in partnership with those developing the curriculum worldwide, and as we brought out new products, I was kind of right there at the kind of get-go for all that stuff. And the message, honestly, is that the intentions are really good. Nobody is trying to set up CPD and therapeutic products to just make loads of money. That's never ever a discussion that was had in 10 years within Rocktape that I was privy to. So it really is a company with a good heart, and some great education and courses. Well, I hope they're good, because I wrote half of them. But yeah, now it's moved, so it's really kind of the clinic, and then the kind of me as a lecturer for my courses as well. So that's what I'm concentrating on these days.
I'm sure there's a few people who have, like, for example, Timothy says he remembers you taught the
yes,
course at Bath University.
I mean, yeah, like I have taught a lot of courses over the years. Like when you go back through it, and I saw you like way back. Exactly, I'm old, like you. I'm old, and don't let it away. But,
right, steady on, easy.
Well, neither of us look it. That's the point
exactly,
I'm trying to make. So people underestimate it. Although the grey hair is helping with my my senior.
You never had a beard though, have you?
I couldn't grow one if I tried, mate. I can't even do a sideburn. Like I've gone grey before I can in any way complete any sort of facial hair maneuver. Like, yeah, nah. Like Movember is a form of torture for people like me. Like it's some kind of like testosterone-based segregation of men. Anyway, how did we get on to that?
Well, let's
ask me a better question.
This logo, I like your logo and
the Move logo.
Yeah, and you talk about it. Actually, I think you lead off in your therapy live presentation with it, because it's a brilliant logo. It's what every business really needs to strive for, where it says so much with so few words. But yeah, talk us through it.
Thank you. Well, yeah. So the company's called Move because that sort of comes from that idea that we're all movers. The thing that links everyone together is that we move on some level, whether you're an elite athlete or octogenarian with osteoporosis in a wheelchair. Your real aim of sort of seeking the advice of health professionals and therapists is to improve movement. Like the thing linking most things together is that. So that was the Move, and then it's the thing that people always like is hurt less, move better, and understand more, which is 6 words that took me about 2 months to actually kind of boil down to, but really it's kind of the arms of treatment, if you like. That I think that hurt less is so important, and I think that's something that people within things like soft tissue therapists and sports therapists do really well. They intervene. You are by nature as a profession interventionists, and you're really good and hands-on therapy is really good at that sort of short-term help. So it's that stage where we need to be kind, we need to calm stuff down, and we need to reduce threat globally in the system. And that is where what we're talking about tonight of adjuncts is incredibly useful. And then Move better, because I think far too many people see everything from physio to chiro and massage as a passive treatment. You lie down and I do it to you. No pun intended. As in, yeah, it's this basic model where the passive treatment is going to be curative, and sorry, but that doesn't really work. If you're really going to make a big difference to people long term, you have to make them move better. You have to be, as you were speaking to in your introduction, you have to have that background knowledge of strength and conditioning, but also some of kind of normal movement and however else you kind of approach that. But as therapists, I think it is so important that we see ourselves as a split personality, that there is that kind and caring thing we do with people on the bed, but then there is also this more cajoling and kind of trying to influence people positively to actually tackle some of those movement problems that they have as an individual and they've often had for their whole life and like given up on. So the classic is, the 30-year-old who can't deep squat and has just given up and just decided that deep squats don't really matter. So I think long-term change needs movement. And then understand more, because one thing I really pride myself on is like my patient's level of biological understanding. Like if you don't understand what's going on in your body, you are very unlikely to make it better. And it does make me chuckle. I had a patient cancel appointment the other day because his son, who's been a long-term patient of mine, had a bit of a wriggle and a fiddle around with it and basically sorted it out for him, and he no longer needed an appointment. So that's kind of true autonomy, is when patients can do that to themselves, or they can even kind of be able to help out family members, because you've done such a good job of making them understand what pain is, what it represents, and how we can influence it quickly.
There's so much in there. I think we should say goodnight now and just let people watch that back in slow motion and take it on board. It's interesting because I don't know what type of people and therapists. I know some of the people in here, but there's obviously, we're living in an era of social media, and a lot of people resorting to social media it can define what you believe quite easily, depending on who you follow and who you get into and stuff.
Mm-hmm.
But there might be some people out there who are depending solely and still believing what they've been taught, probably on a recent course, that the changes they're making are very much mechanical, that they are lengthening fascia, that they are getting rid of knots and adhesions, and they're getting, or they see that they're getting results. But also there might be people out there as well who have gone down the other route and tipped too far the other way, where they are starting to think, you know what, I'm not even going to touch anybody with my hands anymore. It's all a case of setting the right exercise, making sure they adhere to the exercises, explaining a little bit of pain as well, and then sending them on their way. So one thing I do want to say, in this room, you might fit into either of those categories. So if you do hear something which challenges a lot of what you believe, what you've been taught, feel free to pipe up now. I always say this, you might get a bit angry, because you are going to hear tonight that maybe what you think is going on underneath your hands when you're working on that kind of lump you can feel, or holding onto it for 2 seconds, then coming off and going on a little bit deeper, or melting the margarine as if there's a pound coin in your skin and waiting for your fingers to. You might really believe in it, and that's what you base your whole theory in. But one of the things I'm hoping, I know that Paul will share tonight, is that you haven't got to throw everything out. It's not a case of chuck everything out of the bath. It's a case of just changing a little bit the mechanism behind what you're achieving. Is that fair enough, Paul? Is that okay? It's just like a caveat which I want to make sure people are aware.
Absolutely. I never, I will challenge, but I'm never setting out to offend in any way, shape, or form. And I think really that it's taken me 20 straight years of, I'm really dull. So I'm 40. I went straight from school to uni to become a physio, and I went straight from uni to the NHS and worked there for 7 years before moving into private. I've never done anything else. And in the last 2 years or so, I would say I'm half decent. And there is fascinating research around experience that says basically that therapists don't get any better as they get older and have more clinical time and experience. And so, young therapists, you have to start with what you've been educated in. But what you're talking about at the beginning really is this idea of silos. Social media creates silos of different therapists, but actually it's way older than that. That's why we have soft tissue therapists and sports therapists and chiropractors and osteopaths and osteomyologists and freaking so many. And then you've got people coming kind of invading from the exercise end. So you've got personal trainers with a basic qualification in massage and hands-on stuff. And I think we have to know our own wheelhouse. But if you decide you are either one of those two things, the hurt less or the move better guy, you are shortchanging your patients. And it doesn't matter what you started at. Some of the best therapists I know, who are the best all-rounders, began with massage as their core qualification. I think this superiority complex that things like physios and osteos have actually make us slow as a profession and slow to change, and within us, that's where the pendulum has definitely swung too far. People come to see me for a treatment and afterwards express surprise that a physio wanted to touch them. They've been let down in previous endeavors to treat their problem, in my opinion. But we all see these things differently, and I'm not one of those therapists who thinks that everyone should treat like me, because I understand that I'm a different human to Matt and to the people that I'm speaking to now. And so that influences the treatment that we have. Great example for me is acupuncture. I don't think that acupuncture is the best thing in the world. I don't think it's the worst thing in the world. I really hate having needles stuck in me, and putting needles in other people gives me cold sweats about something bad happening. And so, do you know what? I never got, for 5 years of trying, never got very good therapeutic outcomes from it. But that's about the interaction between me, the instigator of the treatment, the intervention that we're doing, and then the recipient and what they're picking up. And so, any adjunct and treatment modality will get some people somewhat better. That's the first thing to say about people who only treat hands-on. Chiropractors who do no exercise therapy or lifestyle advice in any way, shape, or form still sort out a load of problems every year. sometimes by accident, sometimes on purpose, but it totally works. And equally, other people will have transformational life changes using nothing more than a Couch to 5K app. That can be all that person needs to change in the ecosystem in which they're living. And that's what we are. We're instigators of change, and we have to be able to change on multiple levels, not just on a wiggling and poking tissue level, which is stuck in the body, really, I think is the best way of thinking about it. That as pain science has evolved and developed, and our understanding of the complexities of what makes somebody get a pain or an injury that they can't make better, the dial is just shifted gradually over my career to point more and more towards the nervous system. So the headline is, you're all treating the nervous system already. You're just doing it by mistake and through indirect means. If you are awake to that fact, then you can tailor your treatments to be much more efficient. But that doesn't negate hands-on treatment in any way, shape, or form, as far as I'm concerned. It actually puts it front and center, particularly people who are stuck, like they are having a problem that they can't get over. It has reached a point of inertia. That's when I think adjuncts and modalities are something that we should be using, but as I say, through a neural lens.
I am on your. I mean, you've just said about two of them there, but I love the you're already treating the nervous system, whether it's by mistake or whether on purpose. Is such a great way of setting someone at ease, because it lets us all know you haven't got to chuck everything out. You're already doing what needs to be done. It's just a case of, I always I credit it to Paul Ingram, because I think it was him, but when you know how something works, you can tweak it to make it work better. I think that's also another nice one as well. And that's all we're doing basically, isn't it? We're not saying you have to stop doing everything. It's just when you look into how something works. You mentioned before that you like your patients to know how something is working as well, the kind of process.
Yeah.
That's an interesting point as well, isn't it? Because you can go too far, can't you? I think some people, when they get into understanding pain, try and tell the patient, you run into all these problems of the patient thinking, oh, right, so it's all in my head.
Yeah, yeah. It's the art of being able to talk to patients, make them understand what's wrong with them, and not feed nocebo, right? So not give them more hang-ups and more problems, right? And that's really easy to do, particularly in the world I work in, where so routinely assess people's vestibular system as because well, if you've got a problem that doesn't go away through other mechanisms, that's a very, very likely place that you have dysfunction that's never been treated before. But it's so hard to do that, and then they go, oh, right, so now I've got this thing wrong with my ear as well as this thing wrong with my knee. And if you educate somebody well, what they start to realize is that actually the labels and the tissue-based diagnosis that we give to stuff is relatively unimportant. What they understand is better, more that thing of like how to look after themselves. What do they need in order for them as a unique individual, as a movement ecosystem, to be happier, healthier, and for the system to feel less threat? Because that is, for me, the best way to talk about pain with patients, is to say, this is cumulative threat that you're dealing with, right? You have an issue and the whole threat matrix within your system has just crept up to a point where you can't self-solve. Because we've got to start from biology whenever we're thinking about kind of clinical reason and problem solving. And the first law, if you like, of injury is that it should get better, right? Like stuff heals, right? You walk out of here, fall down and break your leg. In 18 months, your bone has knitted itself back together through a process which is nothing short of miraculous. We don't spend enough time marveling at what the body can do, given nothing more than time, food, water, and sleep. So things should heal, and if they don't heal, what we are looking for is reasons, and we always have been as therapists. So we have, that joint is stiff, this muscle is short, you have lower cross syndrome. We're constantly scrabbling for these neat terms and single sentence diagnoses that explain what's wrong with somebody, but it's just not working out that way from a evidence-based point of view. Like, you take something like low back pain and you're doing a research into an intervention in low back pain, you have to start from the assumption that everybody with low back pain has basically got the same thing wrong with them. And that's why they have a sore low back. And therefore, if there's a good intervention, they'll all respond equally to it. Like, read a pain book. Like, it's not what's happening. So it's not to decry evidence-based treatment, but it's just be very careful about the mantle you put that on. Because if you put that on the pedestal and say, I form everything around that, stick your hands in your pockets and tell people to do any form of exercise that they enjoy, because that's that's what we've got that we can take to kind of the double locked, triple gold standard RCT is nothing. No treatment intervention actually kind of really passes that test, from cracking a neck to rubbing a muscle. Mm-hmm. So we've got to be prepared to kind of create individually tailored things that are, for me, kind of have that neurological bias. And that's why I will, say routine things that are weird, right? But if you really want to understand movement, we've got to understand kind of two basic systems way better, and broadly within neurology, but we've got to understand the physicality of the nervous system, because 90% of your recurrent and your long-term people who hurt in the same place have an issue with a peripheral nerve, which can be easily treated, but it's just slightly odd treatment intervention. So like Shatlock and Butler's neuromobilization type techniques, like I use them all the time, and in chronic pain, they are what's wrong. It's not that your joint is subluxed, or that your rib keeps getting twisted out of place, or that your muscle goes into a spasm for no apparent reason. It does that because the nervous system tells it to. If a joint suddenly locks, it's because it's been under sustained compression through muscle tone for a long period of time. Where does muscle tone come from? The nervous system. Where in particular? Vestibular imbalance. Like that's setting our spinal tone the whole day long. Balance fascinates me. It's the one part of movement most athletes and movers, no matter their level, are completely blind to. How's your balance? No idea. Where do you score? Mm-hmm. No, got no, nothing. So that's where I am as a therapist, is looking at threat. And that started, like I always tell the story, like I just got back from my master's degree in manual therapy. I traveled halfway around the world and spent all of my inheritance on learning to make things go pop. And I was going to do that, right? I was going to be the physio who could just manipulate things, put stuff back in, get things free again, and that was going to work. And that was the model. And then while I was in the process of doing that, I put a bucket handle tear in my medial meniscus, and only had the kind of health insurance which repatriates your dead body as opposed to fixes the living one while abroad. So I had to live with it. And the only thing that made any difference, somebody else on the course had like a roll of tape and was like, you should try this stuff. And like I taped my knee and it was just better. And so like there is things going on. Like, so you've got a clear articular injury there. Like I've got a big hole in my meniscus. I can put a bit of tape on that essentially tightens the skin over my medial compartment of my knee. And now it doesn't feel like my leg's going to fall off when I walk around the corner. That was this massive moment where I just had to confront the reality of what I was feeling as a human being. And I have always been aware of that. I think we need to be. We're all biased because we're all humans and we're all thinking with our own nervous system, which we know is unique, and it's based as much on past experience as it is in present information. So we've got to just find our own kind of path through this stuff. But I understand why people get frightened when I start talking about this. I'm just going to go back to rubbing tight quads, because it is simple if you stay in that. It's simple if you stay in Maitland's view of articular mobilization. It's simple if you just go, everything's a knot in a muscle. I've just got to find the right knot and release the right trigger point and they're going to get better. And you will chase things around. You will change stuff for people because you're sort of accidentally peeling off layers of their kind of threat onion and getting to the core of what's wrong with them. But we can get there faster if we go in with that attitude. What's the biggest rock in your healing river? Because biology should be making stuff better. And when it's not, that's our job to find it. But like just stupid, simple things, right? Like the number of runners who are running with compromised eyesight, right? They're running without their contacts in because sweat gets in their eyes and they don't like it. Right? And they get pain when they run. You get them to run with their full eye support and they no longer have the problem because it's just tone that's developing through threat uncertainty. Like, so a threat can come in lots and lots of different forms. So the classic Descartes model is the guy with his foot in the fire. But a lack of information is just as much a threat to your nervous system as wrong information. So if you just have no sensation in an area of your skin, for example, you can't ever have good motor output around that area because that's just the way your nervous system works. And if you have, back to balance, if you don't know where you are in space accurately, then your body always has to compensate for that uncertainty as it plans movement. And the way it does that is through increased muscular tone. So like those massage therapists who love telling people that they've got tight calves as they lie on a bed, like one, stop it. You can't tell, do a length test. And two, you don't mean tight. You just mean that it's really jumpy and it has high resting tone. And that's a fascinating finding. We can do so much with that, and we can work a lot around that. And that's where so many of our adjuncts is so good, is if we can identify high tone areas of tissue, we can use things like vibration, manual pressure, flossing, decompression, cups, tape. All those things will very often help to normalize muscle tone that's become abnormal through the nervous system surviving threat. I'm going to keep going. The biology.
I'm thinking my mind tends to shut up, but I don't want it, because everything you say is like, I'm still freaking out about the fact that I run without my glasses. But yeah, you keep.
Oh, do you? Right, yeah. Brilliant. Right, so this is.
Well, one of my eyes closes because it's like it's not even needed. When I run towards people, sometimes they freak out because it looks like I'm winking at them, but actually I just run with one eye shut because it's got a bit of a lazy eye.
Yeah, well,
it's not needed.
Anyone with good observation skills will have noticed that I have a fairly significant facial asymmetry where my hang on, wrong side. It's a mirror thing. I just talk out one side of my mouth. So, like, yeah, we all have different neural function. Like, some people can make one eyebrow go up, and other people can't. Our brain is programmed to make us survive because we are the vehicle. So you get deep real quick, right? You are the vehicle for your genes to make it to the next generation. The unit of evolution isn't you, it's your gene. And your genes don't really care whether you get backache at the end of a day. Like, it's just not important to survival. Like, not to belittle the patients that we and you and I and the people watching treat, but they're not going to die of what's wrong with them, right? Nobody's died of back pain. So, like, that is an acceptable change that your body will make if that's the difference between frequently falling over or passing out, which is what can happen if you have an unchecked vestibular problem.
Right, stop.
All your brain wants to do is survive.
Well,
pain is a really short price to pay.
This leads me on to a question which I want to put to the floor now.
We should get to some treatment at some point.
I'll put that trip down. I've only been to Cornwall once, and I ended up losing my virginity, so I haven't gone back there again because
that wasn't me, people.
Good old Nuki. Right, so it was okay. A question for the floor. Here we go. If you've watched Paul's presentation on therapy, on therapist learning, which was for Therapy Live, then don't answer this. But be confident. What happens inside Let's Talk About stays inside Let's Talk About. Won't go any further. But in fewer than 5 words, so please, let's not have just a copy and pasted definition from some kind of, what is the brain for? Maybe 2 words, 3 words. Just write it down now. I'm hoping there'll be at least 4 or 5 of you, because I was very interested with the source you used and the implications of what the guy said on your presentation. So people out there in the comments, let's have a little look. And I promise I will come back to some of the questions which I've seen mounting up in there. But what is your brain for? Dun, dun, dun. I'm not going to, if I see an answer which I know is what I'm expecting, then I won't. Let's see what we got. In there. So we've got
getting me up at 5 a.m. Good, Gary. Yeah.
Matt Scar's book has put the word movement. Interesting. Facebook user, the body. Actually, let's put these up on the screen. Movement. The body's driver. Nice analogy. I like it.
Yeah. Central governor theory.
Or is it the body's pedestrian, warning you, pedestrian drive, kind of sitting next to you driving, going, watch out, watch out. I don't know, it could be either way. That's the problem with analogies, isn't it?
They all break if you go too far, don't they? Yeah. So your brain's like sat-nav, because it's not like sat-nav, because it doesn't need an update.
Buying, your body's brain is for buying running trainers. Thank you, Timothy.
Well, yes. I mean, that's why we treat patients, is to buy surfboards and running shoes.
Processing the senses. Oh, there's enough here for a whole
that's good. Yeah, I mean, and so, like, for those, can I go? Those that haven't,
not yet.
Not yet.
No, not yet. No. Learning to adapt. Jeez, all of these are really. See, actually, we've got a far higher caliber of therapist in the room than I expected.
I think people think I say interesting things, but I think a lot of therapists think like this already.
Mental toughness.
Well, I will assume that's mental.
Somebody's
got fat thumbs.
Or maybe they're just not wearing their glasses.
Mental, there it is. Yeah, exactly. He's only got one lens in.
All of these are possible good answers. Okay, you talk now. But eventually I want you to work towards what you said and the source you used on your presentation, because I thought that was interesting.
We'll just cut to the chase. The TED Talk is Daniel Wolpert, who's a neuroscientist, and he poses the question, what is the brain for? And his answer is complex adaptable movement. So a free toy for Matt.
No, but he's watched your
seen it before
already.
Yeah. But it's the point is complex adaptable. There are lots of things in nature that can move without needing a nervous system. And again, it goes back to evolution. You have to go right back to the kind of slime in the bottom of the sea and what it was doing and what developed a nervous system and what didn't. Because not all life has a nervous system. Not all animals have a nervous system per se. But everything that moves has a nervous system. And if you follow it back far enough in evolution, that's the dividing point. Stuff that got up and moved needed a nervous system. It needed to be able to move away from dark towards light and away from predators and towards prey. Like, so we move to survive, and we have evolved that from the darkest vestiges of the primordial soup, but we have always moved. And the nervous system is just a layering system, right? Mother Nature can't stop and start again. So we contain the kind of vestiges of every version of the nervous system that has existed. And like, this gets deep, like really fascinating. But like, there is constantly, we know from neuroscience, like there is essentially a conversation in the brain before every decision that is ever made, right? Yeah. And the idea that some mental disorders like schizophrenia are essentially when our brain is unable to resolve that to a single answer for us. But that gives an insight into the complexity of what we are constantly doing, right? And how we are controlling our bodies to move. And anybody who's taught a kid to ride a bike or do, frankly, anything during lockdown has just watched them. Why did you do it like that? Like, they're in wild experimentation mode. And it's super important for us to get going. And the link between evolution and movement is really, really important, because we look at the broken adults going, I think our feet are poorly adapted for our bodies. There must be biological flaws with the design of the lumbar disc. And like, to be honest, what we're looking at is really poor animal specimens that didn't spend enough time moving when they are young, because that's how nature programs a complicated nervous system, is through play and movement in youth. And human beings are the most underdeveloped mammals when we're born. Like, think about a baby giraffe. Like, it gets up and follows the mum, like literally after dropping 6 feet out, and then it can feed that day. Like, it takes a human being a year to get to that. And that's because that's what allows us to get so complicated, is we come out so unformed from a neural point of view. But it's probably why, as a species, we are uniquely plagued by pain and dysfunction. It's a combination of the complexity of our nervous system and the way it just responds to the environment. And yeah, somebody said adapt, like the neuroplasticity. It lasts for your lifetime. Every time you create change within a session, not every time, 99% of the time, you've created neuroplastic change. That's what's different. You have desensitized or activated a part of the nervous system which was underactive or oversensitive, and that kind of drifts into that whole view of, sorry, I've got horrible feedback in here.
Still?
It's gone quiet. I'm sorry. There was a noise in it.
Is it okay now?
Yeah, I'll stop. So yes, your nervous system is the thing that's changing, and your brain is for making your body move. Think of it as an equal-footed partnership. Like, a lot of people have this brain in charge model. It's just not what's happening. Like, when you run round a corner really fast to dodge another guy in a game of football, there is no way your nervous system has the time or capacity to micromanage tension in the muscles that are required for you to spring off that leg and not break stuff. So sometimes the body is acting essentially autonomously through local neurology rather than through central governors. So our brain is there to make movement and to process sensory input. That's what it does. But one is behest the other. You only need to process sensory input if you want to go somewhere or do something.
So it kind of fits in quite nicely with the idea that if you want to help someone move better, which is normally why people come to see us, they want to be in less pain, but the pain arises when they try and move. I mean, you can have pain when you're not moving, but a lot of people, they struggle with some kind of functional movement. Yeah. Then your treatment has to involve exciting or desensitizing the brain in some way, hasn't it? Either way.
Yes.
So when you got someone lying down and you might be stimulating them and either invigorating the nervous system or desensitizing it, that might be at the right time, the right thing to do. But eventually you've got to build it up to where you actually
Greg Lehman.
Facilitating movement, yeah?
Calm stuff down and then build stuff back up again. He didn't say stuff. Yeah, but like the opportunity when someone lies on the bed, you know, if you want to be more neural, just open your mouth and talk more and tell them what you're feeling and make it honest, not nonsense babble that you have trained yourself to kid yourself that you're feeling. And that's often through kind of education. But, you know, like any tissue change that occurs underneath your hands, that's tone. So that's coming from the nervous system. We might do something lymphatic and clear away swelling, but why does it matter if it's swollen? It's because swelling puts mechanical pressure on the nervous system. So you keep, for me, the drain just circles back to nerves over and over again as to that's how treatments are working. And we can enhance that hugely by adding a cognitive loop, right? So you're pressing on somebody on something, say you're wiggling their kneecap or rubbing their quad. Like the first step to being more neuro is to actually talk about that, not football and where they're going on holiday. Right, is to say, what's this like to you? Can you feel that naughty bit that I can feel? And it's this interactive conversation where your nervous system is being informed by their voice, because that's the best access we have to their nervous system, is for them to tell us, not what we feel. You can't really tell if somebody hurts. Like a lot of you will have developed habits around palpation where you zone in certain feelings and findings, and that thing is always sore. But I guarantee if that's the way you find soreness, you're missing other stuff that's very definitely sore and potentially more tender. And then I think the other point to make on that when we're talking about nerves and palpation is assess abnormal response to normal palpation, not normal response to abnormal sensation. Like, as in, if you poke it hard enough, everything hurts. If you wiggle around somewhere, you can find something that feels a bit like their sore spot. But always be prepared to compare it to the other side or compare it to an uninvolved structure elsewhere in the body and see whether they really do have a pressure sensitivity in that area. Because I think sometimes if massage therapists are guilty of one thing, it's convincing people they've got problems in their muscles by smashing their thumbs really hard into their muscles, particularly in a runner. You know, Matt, that's good. Like when you're on high mileage, it doesn't matter where you touch in your leg, it really bloody hurts, right? So that's a respective sensitivity. That's what we need to do, is pretend, like, act like their nervous system's level of sensitivity actually makes a difference to what you do today, as opposed to how much you take the mick out of them for squealing like a girl.
But that's where we were talking about, I think, I can't remember which week it was, where therapists we're not really trained enough to be critical thinkers. The first thing a therapist needs to do, if they find something on one side of the body which is painful when they push their thumb in, the first thing that's got to go through that therapist's mind is, I'm just going to check if I push my thumb into the other side, which they're not complaining about, whether it hurts or not. And I still don't think enough, I'm pretty sure all the therapists in here do it. So I don't know who I'm talking to, but it's something which should come naturally, because I think 9 times out of 10 it does hurt as well, doesn't it?
We can all do it better. We can all we all leap in a little bit and go, I think it's going to be infraspinatus. How's that? That really hurts. Cool. Look at me. I'm so clever. But did you check Terry's? Did you check, rhomboids? And is the whole area jacked up? Because if you're finding multiple muscles in one area that are jacked up, guess what you're after? A nerve that supplies all of those. And it's so often, if you're actually careful over that, your palpation skills alone can tell you which nerve is involved. If you just look it up, right, that's those, and there it is, so you will see those kind of clear patterns, particularly around the upper limb where the nervous system tends to be more regular.
Gary's got an interesting question here, as always, of course. I'll bring it up. No, it's not that one. Let's bring up the other one. He sent it a while back, but I've been looking for the moment to bring it in. Here we go. Shut up. He says, I did say that. I saw this on Facebook the other day. He says, it must be true. Where there is pain, there is no movement. Where there is movement, there is no pain. Does this fit in with your view?
No, it's an oversimplification. But then so is everything else. And that's the thing, when you really sort of start diving into the nervous system and realizing that everybody with a pain that's gone on for 6 months has sensitivity. Everybody with pain for more than a couple of years probably has vestibular and cerebellar involvement in their dysfunction. When you sort of really kind of start to understand the nervous system outside of the body, so the central nervous system, then you become really interested in things like eyes and our oculomotor skills, and even our hearing, that can be playing a very very significant part in somebody's ongoing pain, because it's a threat that just won't go away. And we tend to, those neural threats, we're blind to. Everyone is. It's not just, it's not sports therapists. It's all therapists, I think, bar a few. My enlightener, if you like, well, it's a serial thing, right? But the kind of tipping point into true weirdness was meeting Eric Cobb from Z Health, who is a divisive character, who splits therapists. But for me, it's that kind of genius or idiot, and I think he just about falls on the genius side, and he really is for me the person who's taken like modern pain science and applied it to interventional therapy the best. And they do an awful lot of vestibular and visual drills, because those systems are incredibly important to your brain. Whether you like it or not, they matter much, much more than whether somebody recently rubbed a muscle as to how robust and resilient that muscle is to function. So you can have movement but have no control over that movement, and that would be a problem. I think, it is a nice little maxim that relates pain to movement, and the way I would use that, Gary, in treatment is to say to some people, and because so you would like to be pain-free. You can't lift your arm above 45 degrees. We're going to have to improve the movement to improve the pain. And if the movement impairment has become bad enough, it doesn't pay to focus on trying to relieve pain. You have to improve movement, because the nervous system will never accept that as a low threat region when it only moves through a third of its range of motion. So when movement loss is big, that's where we should all start. All therapists need to be way more interested in mobility of all the systems. So the nervous system, the myofascial system, and the articular system. And without full mobility, it's very hard not to have threat in the area. So in that much, it's true, but you do meet lots of people who have no positional sense, or they just have too much range of motion. So bendy girls who take up yoga, get into the wrong kinds of yoga, spend a little too long in some really deep stretching positions, and now their brain perceives threat because the soft tissue simply isn't active enough around the area. So I think, like any statement, it needs qualification, but so does everyone's treating neurology, and that, manual therapy isn't all bad, and that adjuncts can improve everyone's treatment. All of these things are kind of more true than they're not true, but none of them actually stand up to really kind of thorough neurological analysis, because, well, that's the point, is nobody actually knows what's going on. The best are just better at guesstimation than we are, but everything, once you start talking in neurology, everything's a huge oversimplification of the reality of what's actually going on inside the body and the brain.
It's like, I think you said it a couple of times in your presentation, and I love the words you use, because it kind of shows what you've just said. You describe something as being less wrong, which is great. I think that's a great way of looking at it. We don't know what the absolute truth is. We may never know, but we're just working at kind of moving things which are less likely away, and then working in that direction. I think that's a healthy way to look at it.
And that's very much about the story we're telling ourselves in our brain. Like, we need to adjust our treatments a little in order to kind of accept this model, but it's often just forgetting a lot of the rules that we thought we needed to know. So we don't need to remember exactly which joint glide angle goes with which physiological movement, because, hey, we're all different, and we're like, just go to the anatomy. Don't forget the neurology. Like, take your hand bones. Like, most of us have got a joint which is of an abnormal and asymmetrical alignment within our hands or our spine. Like, the majority of people, that's probably true. My anatomy professor at my manual therapy, he was big into his cadaveric studies, and he just had these, like, a drawer full of random vertebrae he pulled out of people over the years. I'm really not sure of the ethics of it in Australia. But, like, C2s, where you've literally got one facet joint that sits like that and the other facet joint that sits like that. And, like, I've had their medical records, no reports of neck pain. So large anatomical variants should be considered the norm, and we have to be careful about what we're feeling as well, because we will often be feeling normal anatomical variants. So we're looking for those things where there is some kind of palpation sign, but there is also a stirring of their symptoms that they're complaining about, or some other factor that makes us think that might be relevant, and not just the randomness of that person that's in front of us. It's that uniqueness thing that, again, comes with complexity. As we're this complicated, we can't all be alike. We can't all hurt in the same places for the same reasons. It's just childish to think so, and that's not to offend people who have taught people in the past, but it is. This is new, right? Like, you go back 10 years and we didn't have a lot of the information we have about just how unique the pain signatures are in something like a bunch of people with chronic low back pain, and then you make them hurt and you see where their brain activation is, and it's just a completely different pattern. It's completely unique. And that's what led to the coining of that like neural matrix, that kind of pain tag in the brain, which is unique to everyone. And it will dart around and it will take stimulus from lots of different systems which aren't working perfectly. And as a therapist involved in movement, obviously the body's the one we want to kind of get our hands around first, being able to treat and improve, but it's being able to recognize people who have problems that come from other areas as well. And that, you said do a strength conditioning course as a new therapist. I would do a clinical reasoning course.
Yeah, we said that as well. Yeah. It's true.
And there's some really good ones around by physios who are open to other professions as well. I'm desperately trying to think of the guy's name who does a good one back on. But yeah, so that ability to think through why somebody might actually be in pain is very often born out of a decent conversation at the beginning.
Definitely.
Massive.
Well, in fact, next week we're going to be talking about that with Anna Maria, about the importance of the subjective.
See, there you are, great example of a health professional who does very similar work to me with a different background in training. And that's the kind of point of, as we get united by pain science, then we can start to share our interventions more, share our kind of thinking and borrow from each other's experience, because that idea that there is a chiro approach and there is a physio approach to dealing with a problem, it's just out of date now. Like, there's more variety within the professions than there is from between. So movement specialist, whatever you want to call yourself, like, just outgrow your professional training. You're not beholden to it.
With regards then, because it's 8:55 now.
Sorry.
So I wrote that pretty rubbish beginnings of adjuncts. Do we really need them? It's more a case of kind of what's happening when we use them. But how would you therefore, because you've mentioned that, okay, so the idea, if we know that an adjunct is stimulating or desensitizing, whatever you're trying to do, the nervous system.
Yeah.
What criteria would you use? For example, you mentioned needles. Now, needles, is it up to the individual? If you feel threatened by a needle, that's probably not the best treatment for you. But then are you saying that if you like the idea of a needle and you believe it's going to work, you could like the idea of a needle and you could be really convinced, you might have read something, or maybe you're just from Glasgow. But no, I didn't say that. But
Trainspotting was filmed in Edinburgh.
Is it? All right.
Yeah.
So, but essentially, my problem with a needle is what could be more invasive and threatening to the nervous system than having a sharp object inserted into you? It's got to, on a
ask
deep
a
level.
Yeah. To you, but if you were brought up in China, then you don't feel like that.
This is true, and the research does show that if you receive it from a Chinese person, our nervous system
is shaped by our experience, right? And like, if your experience is that you've watched your family get better through this process of having needle shugging, it doesn't even feel like a threat. And adjuncts do all work through the same basic mechanism, which is giving the brain reassuring messages that there is less threat from that area.
So someone's a blank canvas and they're saying, what do you recommend? And you've asked them and you've given a great subjective and you've got no leaning towards, well, a bit of this or a bit of this. You've got a table. It's a bit like in, I don't know, some kind of horror film. They've rolled open the carpet. They've got all these invasive little things in a line. What do you try and steer them away stuff? You
want me to say, I guess, Matt? Is that what you I guess?
That's fine. I'm with you on that.
I make an educated guess based on, like, so I think in layers. I think this is something a lot of therapists can just take away and go, I can do that more. Like, does it sound and feel like it's an articular problem, a nerve problem? So does it give nerve symptoms? Is it muscular? Is there stretch and contraction elements? Or is it on the skin? Is the skin just sensitive and jacked up and wound up? And is the skin being insulted in any way through it? And if we can think in those kind of 4 basic body layers, then we can choose an adjunct based on that, right? Because if you have a joint problem, doing a really light feather technique with a blade that's really only affecting hair follicles and the epidermis is unlikely. It's not impossible that it'll give a change, but it wouldn't be my first port of call. Something that affects the deeper layers would. So I would mobilize the joint or I would floss them, because they're things that get down to that layer more. So what layer do you think this dysfunction is in? Then look at the table and go, which one of them kind of is a really good treatment for that? And then why are they here to see you? Ask that question more. Like, what makes you come for treatment? Oh, I just want to know how to deal with it myself. The number of people, and I know I'm a physio, so I'm getting a different crop, but like, you know, it's that question, if you could have one thing, what would it be for the patient, like from at the end of a session? If that's less pain, then go at adjuncts, but be aware of times where therapists are pressuring themselves to use adjuncts on people that don't want or need them, because they are about the help phase. And a lot of people that are coming to see you, they're not bad enough to really, really need anything beyond the massage, if that's what you're doing, or, you know, sticking to those things. More adjuncts isn't necessarily going to make you a better therapist, but it's using them in ways that excite and activate the nervous system more. So that's the conversation, because that gets us in at a cognitive level. And then it's adding movement. So whatever you're doing treatment-wise, think about doing it with movement. Like vibration guns, good or bad, depends what you do with it, right? Like if you lie there and get tenderized from head to toe, like with a piece of meat, I think that's probably quite a nocebo thing to do. If you shake somebody's vertebrae in their neck really, really hard with essentially what's a pneumatic drill with a medical coating on it, then that's probably not going to make them feel much better. But if somebody's completely lost as to where their hamstring even is in space, and you do so I call it muscle mapping, but like basically kind of just taking the muscle through its full range of motion, because that's what we are doing so often in treatments, is we are taking a brass rubbing of that tissue and putting it back in the brain again. So maps, right? Your brain, in order to be that controller, at least semi-controller of the system, your brain has to have a map of literally every inch of your body, how much a muscle can contract and how much a muscle can stretch. Individually, that must be mapped somewhere within our cortex, or at least how much the region can do those things cumulatively, and what the skin is feeling on the area, because our skin's this huge threat sensor, right? Like it's the first threat sensor to any injury is, my skin is tearing, stretching, or being broken, or compressed. But the skin is what talks first. And so that's why a lot of the successful things are quite skin targeted, because your skin's your primary defense. So I think we've got to go in at that level when choosing adjuncts, of saying, what am I most competent at? What am I happy doing as a person? Because you're half of the interaction. And if you're choosing interventions that you feel pressurized by your professional colleagues, the people that you work with, the training that you've had, like I try to do to myself with acupuncture, because, you know, it sounds pretty cool and controlling, right? Like, and I always jest about this, but like, I'm the kind of therapist I am because I'm the kind of person that I am. Like, I talk because essentially you like being listened to. I love those wow moments in therapy, right? So like, you know, the first things that got me hooked was stuff like snagging backs, right? And snagging necks. So you lightly put your fingers on a vertebrae, give it a gentle shove as they turn their head, and they go, oh my God, I haven't seen over that shoulder for 5 years. And it's a real buzz, you know, and it's hard to get away from that, but get addicted to the face, not the intervention that got you there. Because the first thing that gets you there is just happen chance. Like it's just dumb luck as the right therapist in the right time. And mine happened to be a Mulligan technique, and that sort of shot me off in that direction. But I now understand that that lady could have been helped by anything. And the main thing she was helped by was a decent subjective beforehand and a look on my face that said, I really want to try and help. Like, our intention is far more important than the intervention. And the setup that we give to the adjunct is very, very important, I think. You know, why are we doing stuff? Like, to try and make it feel better. And how do you know if it made you feel better? Well, you bloody test it beforehand and after. And that's the selection criteria, is layers, my preference followed by their preference, sometimes the other way around, but you know, and then does it stand up to objective measure? Is it a good use of 5 to 10 minutes of your therapeutic time? Because we are busy, we have many things to do and to try, and so if you do something for 10 minutes and it doesn't make any bloody difference, stop doing it, do something else instead. You should have more options than just banging your head against the same brick wall hoping it goes soft.
Well, I think Gary has summed up what I'm feeling. I'm
I talk too
this
fast.
again tomorrow.
I know, Gary.
So many important points in here. Please feel free to share this so we get messages to wide audience. There is a whole lot of stuff here. I'd actually forgotten how Paul Coker is wind him up, and he will just blurt out clinical goals
any time of day. You know, it's quite sad, really. I have no other real interest.
That's amazing.
In my life.
There's so much on here which I didn't want to. You have, I mean, what did you just say? Your intention is more important than your intervention. You will notice a rap kind of thing going on. I don't think he can get through 10 minutes without doing a rhyme, and he doesn't even mean to. I've got down here, bring attention to your intervention. So it's kind of, you play around with it quite a lot.
Yeah. Well, and that one was, when people say, how do I be more neuro? That's the first step. And that's not just me that said this, is something from like Butler and Mosley as well, is talk during treatment. And Greg Lehman summarizes it as passive interventions are an opportunity to rub them with your mouth.
Exactly.
Not literally, people, particularly not now. Don't go licking patients, no matter your hygiene and COVID standards, that's just not the game we're in right now. But like when you are treating, that's when you should be exploring those things. Can you feel it getting less sensitive? Is it winding it up? Is this a good input for your body to have? Because once somebody's felt a couple of really good inputs, their expectation for treatment goes up, and then suddenly they expect to feel that much better after everything that you do. But that's the thing. What we do should work. It should make people feel better.
Right. People need more of you. Obviously in this current time, it's tricky to get you for your course, but you do a fantastic course, which I want to come along to.
It's a riot. This is
but this is
course number 1. There will be more. This was manual therapy and therapeutic intervention, which was pre-COVID. I did that a few times last year. It really is exploring this idea of threat as the driver. You are a threat reducer. That is our job in a nutshell. Where we should be changing habits and opinions, and we should be reducing threats, particularly for those people in pain. And this course really explores some of those more unusual interventions that I make on a routine basis and see good clinical outcomes from. And it presents the kind of good scientific rationale. Because I am a bit wacky and a bit weird in how I treat, but I have a pretty hard filter, right? Like I don't put up with anything that like doesn't have, if it lacks biological and neurological plausibility, I'm not in. Now I know lots of people put tape in that bracket, but I just don't think they understand the peripheral nervous system and the complexity of skin enough to appreciate how tape can work on that level.
How can people help you? Is this course running, or is it an online?
This course, no, it's a live course. I have no dates in the diary because I am respectfully waiting to see what happens with COVID. Okay. If things don't improve much, then I will look at filming an online version of it. And then the other thought in my head is I might just do a therapeutic movement course, because there's so much we can do with that. And I think a lot of people are scared of the movement side of it, particularly from this world, or at least from the massage world. That's the one bit they just don't feel qualified to do. And how long does it take to become a personal trainer? Like 6 hours online or something. Like, let's not get wound up about the idea that suggesting somebody tries an exercise and see if it helps them, particularly if you're not putting hands on. I don't really think we're treading on anyone's toes by doing that, no matter our boundary. So yeah, we all have to have those two elements. And then Instagram is my only vaguely active thing, which is Paul the Physio with underscores between the words, like somebody who doesn't really understand the platform that they're setting themselves up on.
Yeah, you can Instagram. There's not a lot. Is there much information blogging wise that you've put out there, or?
No,
you haven't got time for that, have you?
No, well, 2 little kids, clinic to run. Hopefully there'll be more. That's all I can say is if we continue in this kind of state of being for a while, then obviously I'm going to have to do some stuff. And these kind of chats are good, but the idea of presenting a whole course down my laptop is terrifying.
Like I say,
machines.
You're on Therapy Live. There's a great 45-50 minutes, which I know you got stressed out because you had to speed through it, like slide at the end. But it's
done it again tonight. I've talked all about the introduction and not really got into it that much. But we can come back. We can do some more. If people want to look at some of those kind of ways that we can think about the practical implications of this, like there's a change in thought process, and then there's this chasm we have to cross when we stand at the treatment table and acknowledge that we understand that it's because they don't love their wife and they hate their job and they're overweight and they're stressed as hell and they're not sleeping well and they're surviving on nothing but a high fat diet, and also they've got a bit of disc degeneration. But it's how we then actually take that knowledge into treatment and how we cross that chasm as to how our intervention is influenced by our thinking. And I think that's, if I have a niche, it's probably that. It's how we actually get from one to the other. How do you accept the modern interpretation of pain and threat, and how do you use that to continue being a interventionalist therapist? Because you should. Don't give up. You just have to change the paradigm. You have to stop relying on your hands to tell you stuff, and you have to start relying on your patient's voice to tell you things. So one of the questions I always tell people, I ask patients all the time, didn't you say you want to do this question?
That must be Morgan. I reckon that's James Morgan somehow.
Yeah, like, you know, shoes are optional through all of my courses and in all of my clinical environments. I practice barefoot most of the time.
That's the name of his clinic. No, he's just
that's his.
It's James Morgan. It's that
physio. One got it. Do it. Sorry, James.
I think it's
slowly.
Exeter,
Exeter. Yeah. Yes. Anyway, I was looking at something.
Come to you, mate. I've just come to Brighton. I'm sure we'll work something
out.
Well,
we just need COVID to be over, but let's be optimistic. The science is going to get this one licked within.
Everyone's jumping in there now. STA will find places on the course. The course doesn't even exist in Gary's handing out.
Well, that's fantastic. It sounds brilliant. Like I'm super keen, and you know, these talks have been really well received. So maybe I do have something to say after all. But yeah, it's getting it into manuals, right? Like that's where a lot of people get stuck. They can think like this, but when they come to make an intervention, they go back to their old way of thinking. They go back to thinking which is the short muscle that I need to lengthen, which is the stiff segment that I need to specifically mobilize. And there's nothing wrong with those types of thinkings, but we can get to less wrong answers. That's the point. But the freedom it gives you and the fun you'll have in clinic, like the wow moments get better. The more the patient generates, the more than you, right? That was the penny drop moment for me, was the best wow moments, or where you just say, do this thing, right? And they do a weird sensory thing, and then suddenly their pain problem is much, much better, because it's just a better way to create positive change than always rely on that interventionalist model.
Right then. I'm hoping.
Okay. Sorry, Matt. You should have known.
That's great. I'd forgotten, mate. I'd actually forgotten. COVID-19 has been so quiet now. No, it was great. At the conference, I think you were one of the only people who just got everybody doing your kind of like tricks and things just to get involved. You got everyone working and moving. The only speaker out of 10 which had everyone moving. This year, we're going to actually have half practical sessions thanks to you. And everybody said that was great with Paul because he got us moving and out of our chairs. I thought, it takes the movement nerd to actually get everyone moving.
Well, just stop shutting your goddamn treatment doors. Like, show other people what you do. Discuss your interventions in detail, because like so often people have this idea they're both doing like a trigger point release of a hamstring or something, and like what they're actually doing is completely different. But yeah, I think we need to exchange ideas much more between individuals and between professionals. For young therapists, like, get attached to people who are a little older in the tooth, and really respect clinical excellence where you find it. And try and spend time in the company of people with much more experience in your job, because like I learned so much that way. I'm very practical. I don't sit down and read lots of long textbooks. That's just not the way my brain works. So I'm a doer rather than anything else. And those people who I'm criticizing their way of thinking, they taught me a huge amount of what I know. And there are young people listening to this who in 20 years will be giving a talk that says, you know, now we know all this on top of that. People used to think it was about the brain, the idiots, you know. Like nothing stands the test of time. So we need to be kind when we look back over historical education, historical interventions. Good treatments, bad models. That's the basic idea. The treatments don't change that much. They kind of get freer and easier, but the bad model is the thing we have to fix in our head in order to I'm
gonna have to just throw them out, aren't I? I'm just gonna have to. Yeah, should I just get rid of them? Oh, sorry, he's still there. I've never just chucked someone out of the room before. I'm waiting for you to finish on a bombshell, and I haven't even mentioned the word skin put, which I think is just a fantastic thing. But don't say anything. I'm just going to say skin put. Next time we'll mention the word skin put. What a great word. Was that yours?
Yeah, I think so. I can't think where else that came from. So yeah, amazing. I think I'll claim that as a nice way to think about a lot of the adjunctive therapies. If you want something to think on about adjuncts, what's passive in a passive modality?
Yeah, we didn't get to chat about that, did we? Next time, can we have you back? No,
anytime. But like, that's a really good thing for people to think about. Like, is when we start talking about passive modalities and adjuncts, it's only the way you're using them that makes it passive. A floss band can be an enhanced exercise. A foam roller is a good example of an augmented movement therapy, right? That's a better way to. Foam rolling isn't passive. The foam roller is passive, but when you get on it and wiggle around, it becomes movement based and therefore neurologically defendable. So
you're gonna have to have you back, mate. Yeah, we'll chat. We'll get you back. I'm sure people need you back, and this time they'll be prepared. This time they'll make sure they've got a lot of sleep the night before.
maybe
not work too
like
hard during the
play it
day.
on like 0.75 speed so they can understand
get their paper and pen ready and stuff. Right, no, thanks so much.
I've had a
Happy
ball.
time.
I always love talking to you, man.
This is going to be the show that people need to watch back again, and yeah, like you say, play it on half speed or something. But thank you so much. I'll send you back down to the lobby, then I'll come back and say bye-bye to you.
No problem at all.
Personally.
Thank you all very much for your attention.
Thanks, Paul. Thanks a lot.
Cheers, guys.
I'd forgotten. Okay, don't look at me like that, everybody. I've forgotten how great a talker he is and how continuous it comes out. That was amazing. Thanks so much to Paul Coker. Fantastic. And I can see the comments are still going. Yeah, brilliant. There's so much there. You will need to play that back and listen to it. Believe me, I've heard him before many times and been to courses. But even I was thinking, oh, I'll mention that, or I'll mention that, I'll mention that, and it's all just gone. So yeah, it will be on YouTube. It stays on Facebook as well, obviously. But like I say, on YouTube, they're all there. This one will be there in about 3 or 4 days' time. I just need to upload it. And if you do find our YouTube channel, Sports Therapy Association, then do subscribe. It looks a bit rubbish when we've only got 8 subscribers because it's new. So yeah, just you're not going to get bombarded with spam mail and stuff. It's just us. So if you do go to YouTube, find Sports Therapy Association and just hit the subscribe button. All it'll do is notify you when a new video is uploaded. So there you go. Right. I'd like to say that next week will be less intense, but it's so not going to be, because next week we're going to have, it's going to be equally, if not, it's going to be the same, but with more hand movement. Okay, because next week we have got full red-blooded Italian Anna Maria in the house, who I don't think was in here this week, but it doesn't surprise me. She's one of the busiest women I know. But Anna Maria Mazzieri, excuse me for the pronunciation, clinical director, senior lecturer, oracle of everything you need to know, is going to be talking about the importance of the subjective assessment, particularly in the current climate as well. So I imagine we'll be talking also about subjective assessment, maybe in your consultation, to check whether your client really needs to come into clinic. So that's an important part of the health and safety aspect of COVID-19. But yeah, so Anna Maria herself is going to be speaking next Tuesday at 8 o'clock, which I'm very excited about. Yeah, so join us for that. There's nothing coming up for my Run Chat Live at the moment. I'm taking a bit of a break because the kids are on holiday, basically. And I've got to organise some things for the conference. Those of you who have been emailing me, asking me about Run Chat Live conferences, it's still going to be live. I'm about to release, actually, I haven't said this yet, but I'm going to sort it out at the moment. Stage 2 is where we move into the international speakers will be via video, via internet. It'll still be live. We'll have it on the screen, but we've got to make a decision now regarding air flights and all that sort of stuff. So the 3 speakers coming from the United States, which is a tragedy because Matt Fitzgerald was going to come over. We were going to have Alice Sanvato was going to come over as a fantastic massage therapist. Who else from the States was going to come over? Oh my God, this is embarrassing that I haven't got them. Oh, Kevin Maggs. Yeah, we've got to make a decision. If something changes last minute and they can get flights, then maybe we'll sort it out. But I just need to move with what the current thing is. I'm still hoping that the national speakers will still be able to make it down to Brighton. And we're obviously presuming there's not going to be a second peak. If there's going to be a second peak, it's going to happen basically in the next week, isn't it? Because blimey, when you look around and pubs opening up and all this, they really are testing it. But hopefully we'll still have the conference. It'll still go out live. We'll have 7 national speakers, and then the 3 international will be piped in live as well from the States. And then if things get bad, the conference will still be there. It'll just be all online, but we'll still give it a live feel very much because it is Run Chat Live. Anyway, that's just for people who've been emailing me about Run Chat Live. Right, this has been Let's Talk About Sports Therapy Association Open Group. Do share these, spread these. It is an open group, so we are inviting people who aren't in the Sports Therapy Association in to watch it. Obviously, when they see what a great group we are and how lovely we are and how useful it is being a member, then they may well sign up, which is fantastic because the more members we've got, the more different backgrounds, the more problems people have got, the more solutions we can together find, and the more we will move on, both as individuals and as an industry. So yeah, do share these things, let people know about us. But until then, yeah, stay safe. I hope those of you who are opening your doors are finding it not as stressful as maybe as you thought, how we're getting used to the different priorities and safe things we need to be doing. It gets a little bit weird, doesn't it? Maybe we'll talk about a little bit next time with Anna Maria. What you thought was going to be totally impossible, maybe hopefully is possible for a lot of you now. But anyway, maybe some of that next week. Thanks very much again for tuning in. We'll see you next Tuesday at 8 o'clock. Same time, same place. Speak to you soon. Bye-bye.